Okay, friends, it's time to get real. What we're talking about with getting real is naturalistic observation. So what does that really mean? You know, we just came off the heels of hearing about very tightly controlled studies where we have folks who are enrolled in a study for a very specific reason. They're given a very specific dose. We do a very specific number of interventions and follow-ups with them, highly controlled. Naturalistic observation is the opposite of that. The scientists involved in the studies have absolutely no control over what the research participants are doing. We are simply observing what is happening naturally. So we're really excited to bring to the stage 3 scientists who are doing this type of naturalistic observation. We're going to start with Jérémie Richard, who is from Hopkins, Johns Hopkins. Jérémie, please join us on stage. So Dr. Richard is a counseling psychologist and Banting postdoctoral researcher. We're going to welcome up the rest of our panelists, and then we'll launch into each individual presentation. Next up, we've got an assistant professor from my alma mater, Washington State University. This is Crystal Lederhos Smith. Thanks, Crystal. And last but not least today, we've got a PhD candidate from the University of California, San Francisco, and Imperial College London, I think. Imperial, right? Hannes Kettner. Hannes, thank you. And so, let's see. Hannes, I think you're up first? No, sorry. Jérémie? This is you.
Oh, yeah, this is...
There we go.
Okay, let's get the naturalistic observation started. So hi everyone, my name is Jérémie Richard. I'm a psychologist and postdoctoral research fellow at the Johns Hopkins School of Medicine. Today I'll be presenting some research coming out of our lab. The title of my presentation today is Patterns of Change in Mental Health and Substance Use after Psilocybin Use, the results from a prospective longitudinal study. A few notes on disclosures. So there's notes on the funding here received for the research project and also for the CPCR, our research center. Overall, the researchers had no input into what has been designed here for this presentation, and I think that's important to note. So a brief overview for today. So I'll be presenting the results of a longitudinal research project looking at people that were planning on using psilocybin that decided to respond to this survey that we had both before and after this psilocybin experience. And I'll be talking about the various changes at the level of mental health. So a few notes on the study design. So there were a total of 6 measurement points that we had here, labeled time 1 or T1 through time 6, T6. All respondents, like I said, were already planning on using psilocybin and volunteered to respond to these survey questionnaires. So what we could see here, time 1 was at point of consent. Time 2 was 2 weeks before their planned psilocybin. Time 3 was 1 day before. Then they had their psilocybin session. And then time 4, they responded to the questionnaires 1 to 3 days later. For time 5, that was 2 to 4 weeks later. And then time 6, that was 2 to 4 months later. I'll be focusing primarily today on the results taken from the time points 2, 5, and 6, as there were repeated measures at those time points. So here's a little note on the number of respondents to this survey. We'll look at time 2 as representing the whole of the sample, because this is really where the first large battery of questionnaires were. So there were 2,833 at that point. One thing to note with longitudinal studies is that there tends to be attrition over the study periods, and that is one of the limitations of this form of data collection. We could see at time 5, we had about 41% of the sample remaining, and then at time 6, 23% of the sample remaining. So it is a limitation, but since we still have a sample size of over 650, we could derive some interesting conclusions based on that. Let's look at the respondent characteristics. So they had a mean age of about 40, 54% were male, 80% white, 80% from the US. Only 14% had no previous psychedelic use, and 30% had a history of either a mood disorder diagnosis or an anxiety disorder diagnosis. So beginning with the meaningfulness of the experience, perhaps a good way of thinking about the meaningfulness of psychedelic experiences in these naturalistic contexts is to maybe compare it to what's been seen before in some of the clinical trials. So one landmark study that was conducted by Roland Griffiths and colleagues was found that 67% of the sample of healthy volunteers reported that the psilocybin was either the single most meaningful experience of their lives or among the top 5. In this study, we actually have to go down all the way to once a year to reach 67% of the sample. For a lot of people, it was meaningful, but not as meaningful as what we first saw in clinical settings. So to me, what this suggests is that these experiences in the naturalistic context may be less personally meaningful than experiences in the clinical context. However, this was a sample of people that had previous experience with psychedelics, so it's possible that this experience wasn't as meaningful or significant as previous ones, and talks about characteristics of set and setting also. Looking at general effects of mental health, what we could see comparing time 2, so 2 to 4 weeks before, to 2 to 4 weeks after, we noticed some decreases in depressive symptoms that were maintained 2 to 3 months later. We also see some decreases in personal burnout, so this is emotional exhaustion. We see a recovery there, although it's less pronounced than what was seen for depressive symptoms. Then for burnout related to work, we could see a similar decrease, but it's not as strong of an effect. Interestingly, on the more positive psychology side, we can see these increases in cognitive flexibility, which is a measure of one's ability to think and behave adaptively. There were increases in this across time, and there was no effect at the level of physical health. So given these broad range findings, I was personally interested in really looking at patterns of change and types of responders to psilocybin use based on mental health and substance use or addiction measures. So I asked the 2 following research questions. The first one was, what are different types of responders to naturalistic psilocybin use with regards to these depressive symptoms or alcohol or drug-related problems? And second, how do these different types of responders differ with regards to other psychological factors both before and after psilocybin use? So to answer these questions, I utilized something called latent class analysis. What this is a type of analysis that seeks to identify qualitatively different subgroups of responders, specifically in this case, psilocybin users. And these latent classes were derived based on scores for a depression inventory, Beck's depression inventory, the alcohol use identification test, and the drug use identification test, both of which are scales looking at problems related to these behaviors. And greater scores on these questionnaires indicate greater problems. The results of the latent class model indicated a 6-class solution that best fit the data. So there are 6 groups of individuals here that I'll talk about briefly. The first one, this was really the largest group at 81%, were individuals that had improvements in their depressive symptoms. Second, there was a smaller subgroup that experienced improvements in their alcohol-related problems and also their depressive symptoms at about 7% of the sample. Then we have those that had improvements related to their drug problems and depressive symptoms at about 6%. And then for class 4, I see this as a subgroup of class 1 and 2 and 3, where they had a major improvement in depressive symptoms in their drug and alcohol problems, and I'll be showing some graphs of that, although this group was very small. Then class 5, there's actually a group here that had a worsening of their alcohol use problems after naturalistic psilocybin use with no change in depressive symptoms. And then there was also a small subgroup that actually had a worsening in their drug use problems, despite improvements in depressive symptoms, which is quite interesting too. So a few charts to show the data, starting with these depressive symptoms based on the classes. What you could see here are the 6 classes and 3 different time points, and time 2 being in orange. And what we could see that's universal across these classes is that there was a significant decrease in those depressive symptoms and a maintenance at time 6. Looking at drug use problems, this largest class, class 1 at about 80%, had no problems related to drug use. So that kind of explains the finding there. But then we could see here for class 3 and 4, those are 2 that had a decrease in these drug use problems, and we see that linearly over time. Paying attention to class 6 on the further end, this is the group that didn't have any drug use problems at baseline, but then developed these drug use problems after, which is something that we're going to talk about. Then finally, looking at alcohol use problems. Once again, class 1 just didn't have these types of problems to begin with, so we expect no change here. But then class 2 and 4 are the ones where we could see this decrease, even to below the threshold for an alcohol use problems. And then class 5 is this group that experienced this increase. They had problems with alcohol before and had even greater problems with alcohol after their psilocybin use. Here's a different way of visually representing the data. We could see here at 0, that indicates no change in symptoms. If you have a negative score, that's a decrease in symptoms, and a positive score is an increase in symptoms. And what we could see here, once again, is class 1. We see that decrease in depressive symptoms. Class 2, alcohol use scores and depressive symptoms went down. Class 3, drug use and depressive scores. And then class 4, really this major change for certain individuals with both of these problems. Then looking at class 5, this is the group that had actually greater problems related to alcohol use and drug use. Their depressive scores didn't really seem to respond to psilocybin, so that's a class that I'm personally interested in investigating further as to why that is. And then for the 6th class, this is the group that experienced a decrease in their depressive symptoms, but an increase in drug use problems. And one of the limitations of the questionnaire that we used is that we don't know what drugs they were taking. So they could have been taking psilocybin over and over again, and we wouldn't know that. So that's something that needs to be investigated further. So for the last 30 seconds that I have, I'm going to power through some additional differences that we could see based on these classes, comparing the baseline results to the results at time 6. What we could see when it comes to personality, this trait neuroticism, which is a trait related to emotional volatility, we could see that class 3, 4, and 6 had elevated scores at time 2. Then these scores were normalized after the psilocybin experience. We could see the same thing in class 4 and 6 when it comes to trait anxiety, that these scores then came down and there were no differences between the groups after. On a more positive side, we could see cognitive flexibility in one of the groups that had lower scores. These results were also normalized in class 4. And then finally, spiritual well-being, we could see the same effect, whereas even if they started lower in this degree of how well they felt spiritually, these were brought up and there were no more differences between the classes after psilocybin use. So that's my talk. Thank you everyone for your attention, and thank you to my collaborators.
So as Kevin mentioned, it's really, really difficult to take your entire career and smash it into 10 minutes. So thanks in advance for your grace and understanding that there's a lot of really exciting material to get through in what's quite a little amount of time. Next up, before I welcome Crystal to the podium, I'd like to remind you all that there's lots of time to submit questions via the Slido app. And if you need to download the app or if you need help on orienting that process, there's some QR codes in the back of the room. So next up, please welcome Dr. Lederhos Smith.
All right, so in true academic fashion, I have way too many words. This will be consistent throughout the entire presentation, so I hope you can glean what's important and ignore all the junk. The title of my talk is Apogeotropic Growth of Underground Psychedelic-Assisted Psychotherapy, Provider Perspectives of a Novel Therapeutic Emerging in Spite of the Force of Legal Constraints. And yeah, it's really long, huh? I love that word though, you guys, apogeotropic. That means to push up and out of the earth, right? In spite of the force of the pressures of the earth coming down on a mushroom, it grows up and out of the earth in this manner. And I feel like that's perfect, right, to describe what's happening with psychedelic-assisted psychotherapy. All right, disclosures we can come back to if anybody wants to know. Everybody knows what this is already, so we'll keep moving. So what the purpose of this study is that I'll talk to you a little bit about is to look at this underground psychedelic-assisted psychotherapy and what providers' perspectives and processes were. We know that there's been a lot of progress that's been made underground that clinical research isn't 100% privy to, mostly because of regulation, right? And so we wanted to explore that. We did in-depth interviews with 13 psychedelic-assisted psychotherapy providers, primarily through email invites from the Center for Novel Therapeutics and Addiction Psychiatry. Big shout out to them, to Nathan Sackett, my collaborator on this, for assisting in facilitating that. And I just wanted to say, we can come back if we want, but we went to great lengths to try to provide safety and security for the people who talked with us. It obviously it's a dangerous thing to do, to talk about this, and so we tried our best to keep people safe. All right, now the fun. All of these things are what we talk to people about, talk to the providers about. We ask them, how do you monitor your clients when they're with you? What does your session planning and follow-up look like? What's the experience like of guiding people? Do you have any personal experience yourself with using psychedelics? How about obstacles you've run into? And then, what kind of research should we be doing? And what should be happening with policy, in your opinion? So, we had conversations about this. A lot of text, of course, right? But just to kind of characterize who we talked to, all of our participants practiced in Washington State. Many of them also practiced in other places, other countries, other states. About half had formal training in PAP. And most of our participants actually were either retired or had other jobs, like being counselors or managers, students, software engineers, life coaches, and musicians. Everybody had used psychedelics personally. Everybody had used psilocybin. Here's some just stats on that. And now the fun. So we did these interviews, we had them transcribed, and then we spent hours reading through and discussing what are the general themes that we're finding? What are we learning from this? And we came up with 5 themes. The first theme was that providers were inspired by their personal experiences of self-healing that they found through psychedelics, driving them to share and promote their positive effects as an expression of altruism. Obviously, this isn't surprising to you guys, right? We've heard this over and over and over. So some quotes will follow each of our themes that we have. The one that I love from this is, it's an experience of joy for me. This is what participant 4 said. Gratification to see other people, to see their eyes open to different things, new possibilities, to let go of unforgiveness, to let go of pain, to embrace spirit. The experience for me, I feel like, there's a sacred responsibility aspect to all this. I'm getting to be witness to someone's rebirth. The second theme that arose is a continuum. So beliefs surrounding the mechanism of action for psychedelic-assisted psychotherapy really existed on a range, from the perspective of more of a medical model all the way to a spiritual intervention, and I really loved the term used this morning of the connectedness. But there was quite a range that we saw in how people referred to this. So with people referring to the medical model system as, I think I do prefer these medicines over pharmaceutical medications. I recognize that some people actually do get better with pharmaceuticals. I'm open to what is right for the specific client at the right time. And then all the way to a very spiritual model kind of purview, saying the obstacles are that people are not being educated about these medicines and the healing potential. Our society has not accepted this work as being valid. We're so steeped in the medical model. I think that's a huge impediment to healing, the medical model. The next theme that we found was that each provider articulated a standard set of core processes, and that involved screening, dosing, and planning. And that formed the foundation of their client care, but then they made medications or modifications based on each particular client. So for example, participant 6 said, the psychoactive substances are catalysts, and this work is not dose dependent. The reasons for their choices are based on their health, their experience, their state of being, their intentions. The fourth theme that arose was that providers believed that the client benefit was actualized through their own intrinsic ability to heal themselves, stating things like, it's really wonderful or really powerful to witness people discover the divine nature of themselves. And that's how I think of it, to watch people heal themselves. Like I said, I don't do a lot to get in the way of the process. It's like watching someone discover spirituality for the first time in an embodied way. That's incredibly powerful and life-affirming for me, and validating of my own beliefs and my own healing that I've done. Yeah, it's incredibly life-affirming work. Finally, our last theme that arose actually was a bit surprising to me, and that's that providers expressed an overwhelming sense of dissonance regarding psychedelics legalization. So people talked about really desiring increased access for folks and decreasing the risk that they were taking as providers, but they had huge concern about depersonalization of the work, and that legalization would create an excessive rigidity and decrease the spiritual component that they found to be helpful. So for example, participant 1 said, it's good and bad that there's no gatekeeping, and then it's gonna be good and bad when there is gatekeeping, because there's no restraints, there's no accountability on other people in this space. There's some really screwed up people that get into this stuff for purposes of their own ego and their own gratification. So, what we wanted to learn, what we did learn here, was that this research really allows us to elucidate the current underground practices, and the intention being that that will help us shape research, protocols, interventions in the future. There's one huge takeaway from this, and that is that the flexibility and personalization that are present in that underground world, that's of the utmost importance to providers, right? So much so that when we started discussing policy, people were hesitant to even put their own safety and security first by promoting legalization, because they felt that that would create rigidity and it would lose the personalization of the treatment, right? That information is unobtainable through clinical research trials. And that's why it's so important that we do these naturalistic observations at the same time as we're running the clinical research trials, right? We need all of this information. So, continuation of this line of research means that we take these findings and we bring them into the studies that we're doing. We're bringing them into conversations about policy, above ground practice. All of these things need to be integrated, and that's very, very important. And I would say, as a continuation of that, for all of the folks in the room that are doing or considering doing work like this, don't be afraid to reach out to the scientists, because if we can be measuring and tracking some of the things that are happening, it'll allow us to identify the factors or the components that are going to be important, or the things that work best for particular people, and that's so important. Just a quick thank you to collaborators. I also mentioned Nathan Sackett earlier with University of Washington. Thank you to Washington State University for funding this.
That's fantastic. We just heard Roz calling out this morning the need for more qualitative work, right? Descriptive work rather than quantitative work. So thanks so much for your contribution, Crystal. Next up, we've got Hannes Kettner.
Okay, thank you very much. So when I moved 2 years ago from London to San Francisco, a big reason for that were not only the number of November sun hours, but also the policy changes happening here in neighboring states. So I'd like to start this presentation by expressing my deep gratitude and appreciation for so many people who are here in this room today, who've been instrumental to this change, especially the underground facilitators, but also entrepreneurs, scientists, and advocates, of course. So for the past 6 years, my research at ICL has been focused at psychedelic retreat centers and naturalistic use of psychedelics, and the question to whom and under what conditions these types of settings can be beneficial therapeutically. But I think as these treatments are becoming more and more available to a broader audience, is equally as important as this question will be the question to whom they can pose some significant risks. And so today I'd like to focus on one such risk. It's been recognized for a long time, which is HPPD, or hallucinogen persisting perception disorder, which according to our trusty DSM-5 is defined by 3 key criteria. The first one being the re-experience, and that's really the characterizing hallmark of HPPD, the re-experience of enduring visual alterations after taking a psychedelic, also when sober. So this could be colors or geometric patterns emerging from blank spaces or surfaces, sometimes expressed in what's referred to as visual snow syndrome, so like a grainy TV static across the entire visual field that can increase or decrease over time. Some people experience trails of moving objects or intensified after images of high contrast objects, like in this video. Here is a depiction by a Reddit user who tried to recreate his experience with HPPD, where you can really see how impairing overall these effects can be. It should be said, however, that this is rarely the case. So as we'll see later on, one of the key reasons why HPPD isn't diagnosed more often is that it actually has to be significantly impairing and kind of messing with people's daily regular functioning, which often isn't the case. Often these symptoms are more mild. And lastly, other types of conditions like brain injury, infections, or schizophrenia need to be ruled out, and it needs to be really based on the psychedelic use. In terms of prevalence, the DSM offers us a number just about 4% of people who use psychedelics. But when we look at recent evidence from controlled studies in naturalistic settings, those 4% don't really seem to hold up, at least when we focus on controlled research, where over recent trials, there have been literally 0 cases of HPPD following controlled studies. In this study from Switzerland, there were, I think, 8% of participants who had some kind of subclinical visual after experiences after administration of either psilocybin or LSD. But those were perceived as distressing only in 2 cases and not at the level that would lead to a diagnosis. So when we look over to naturalistic use, though, the picture becomes very different. So in a study from 2011, Matthew Baggett found a whopping 60% of Arrowhead users having experienced some kind of visual alterations after taking psychedelics when sober. Of course, Arrowhead users will be more on the intensely psychonautic side of psychedelic users, so perhaps a more representative sample from the UK found 40% of psychedelic users to have some kind of long-term changes in perception, with 3% saying that it actually drove them mad at some point, so probably qualifying for a diagnosis of some sort. So how to make sense of this apparent discrepancy? There's a few possible explanations, and depending on your perspective, some of these might be more favorable than others. From a drug manufacturer's perspective, of course, one easy explanation would be that it's about the drug. Pure medical grade GMP drug as opposed to homegrown mushrooms or street drugs. Another more complicated answer would be that it could just have something to do with the therapeutic environment, as opposed to the potentially sensorily more overwhelming recreational settings that people use psychedelics in. And then lastly, and this would be perhaps the most uncomfortable answer for controlled research, is that the bias could also be on that side. So because of the tight screening, we actually lose those participants in clinical trials that would be at higher risk of experiencing kind of adverse events or something like HPPD. We tried to provide some preliminary answers to these types of questions in a study that we ran on people planning to use a psychedelic, where we asked prospectively at baseline some questions about their mental health, personality, drug use history, as well as demographics. And then after the psychedelic experience, we asked them what type of drug they used, what dose, and what type of setting, how their experience was. And then at 4 weeks, and also 2 years later, we asked about DSM-5 kind of based HPPD symptoms. And so what we found was really quite similar to prior naturalistic research, in that about a third of people of participants reported at least one of those visual symptoms that we assessed, but only 2 of these found them to be distressing. And perhaps looking at the most common of these visual experiences explains why so few have been distressing. They're more on the milder side, so intensified colors, for example, or positive after images that you do also experience in normal vision sometimes. At 2 years, the ratio was remarkably similar, with about a third, again, of people experiencing one of these symptoms, but only 1 person experiencing those as distressing. Interestingly, repeated psychedelic use in those 2 years did actually not predict whether or not someone would experience a symptom. Which brings me to the next part of the presentation, which is the question of risk factors. So for this, we basically ran a logistic regression model, which would allow us to keep all the other factors consistent while looking individually at how does each of these different factors contribute to the risk of reporting at least one of these visual symptoms. So we're included here variables related to the drug itself, variables related to the context and the experience, and variables related to the individual person who signed up to the study. And the personality trait absorption actually emerged as the strongest predictor of reporting one of these HPPD symptoms. Some might be familiar with this construct. It's one of the best validated predictors of the intensity of acute psychedelic effects, and describes the tendency to immerse oneself in sensorily experience. So this could be either external, like a movie or a piece of art, but also internal, so the own imagination. So perhaps with that contribution of also visual imaginativeness to this construct of absorption, it's not surprising that people high on absorption would also tend to experience these types of visual alterations after taking a psychedelic. The second strongest predictor, and that's a bit more problematic in some ways, that we found was age. So with every year that a participant was younger, the likelihood of experiencing or reporting an HPPD symptom was 6% higher. To the extent that adolescents, so those who were 24 or younger, were more than twice as likely as other adults to report an HPPD symptom. And it's interesting because most clinical trials so far haven't enrolled many young participants. Usually the average ages are in the mid-30s to 40s. Really raises the question of where do we want to set age cutoffs. Adolescence, of course, is also known as a vulnerable plasticity for other neuropsychiatric disorders, and intuitively it does make sense that an already very plastic developing brain would react differently to adding another neuroplastogen to that mix. Next, and this was a big predictor as well, was polydrug use. So half of the sample actually used another drug alongside the psychedelic. The most common used was cannabis, which was also the most predictive for reporting HPPD symptoms. Unfortunately, in a way, because we also found in this different study that low doses of cannabis actually attenuated some of the challenging aspects of psychedelic experiences. So when you're interested in this type of research, we also did something similar on MDMA. I will share all the papers later behind the QR code on the last slide of the presentation. We also found female gender to be slightly predictive of HPPD symptoms, as well as being in a retreat setting, which was actually protective. So 85% reduced likelihood in retreat settings. Lastly, and this was only trend level significant, LSD users seemed to have a higher incidence of HPPD symptoms than psilocybin users. So in summary, we could confirm some of the prior naturalistic findings that HPPD symptoms are actually quite common, but very rarely severe or impairing. In terms of risk factors, there are some easily avoidable ones, like polydrug use, which will probably never really be relevant to treatment protocols in regulated settings. But then also other factors that will be relevant to those settings as well. So we can probably also all agree that females shouldn't be excluded from psychedelic studies. So shouldn't be people who are highly visually imaginative. So yeah, there's some difficult conversations ahead. For example, also around like how do we balance that potentially elevated risk in younger people versus the need to come up with answers to an ever-increasing youth mental health crisis. So I think where the discourse and the science really needs to move is away from the question who should be eligible, who should receive psychedelics, to who gets the most benefit out of what type of context, and what makes these environments better and safer than others for some people. For example, in retreat settings, is it the psychological support, is it the calm sensory environment, or perhaps the use of eye shades as they're also used in other clinical trials. I'll skip over that as I'm already a minute over time, and just conclude by saying that we'll certainly find more adverse events in the future, some that we won't be prepared for. We won't know necessarily why they happen to some people and not to others, but this type of naturalistic data can really help us be a little bit more prepared for these conversations that lie ahead of us. And so let's not miss this great opportunity that we have here in Oregon to help make psychedelics safer and more beneficial to everybody. So thank you for your attention.
Some fascinating stuff there. I was trained by a person who spent a lot of time investigating sex differences, specifically with cannabinoid responses. But I'm particularly sensitive to, folks that are, from the LGBTQIA plus communities, and our audience is really interested in, your work as naturalistic investigators. How do you think your representation of those communities compares to the more controlled research studies? Not necessarily who's doing worse and who's doing better in terms of representation, but what are some challenges, or what are you observing?
I mean, perhaps if I can start, I think there's different types of biases to both types of settings. So in the naturalistic work, especially in the work with retreats, we do see, for example, that it's a very white and kind of highly educated and fairly affluent sample that would attend these types of ceremonies and retreats, and perhaps not as diverse as the people who use psychedelics outside of these types of controlled settings. I think in a way what needs to happen is more research specifically on these types of groups, and perhaps also working with some of the facilitators who are specialized on working with, for example, LGBTQI groups, which we're hoping to do in the future, as this work is already being done. It's just the science that's lagging behind in a way.
Mm-hmm. I would say, in our study, not a fatal flaw, I would say, but something that we overlooked was to track those metrics. Our sample was a convenient sample, so it's going to be, whomever is willing to talk to us at the moment. But I do think that there's a lot of value in some of the steps that are being taken by the funding agencies, and in particularly to open opportunities specifically for people who are underrepresented or may have a different perspective than the, white, male, typical, or, highly affluent folks who are in academia, more pronounced. So, a lot of these opportunities they're coming up, and if we can get people with different perspectives who are doing the research, then we're going to be able to integrate a more fair and appropriate viewpoint all around. And I think that's one of the ways that we can work towards that, is to continue to support those kind of opportunities for folks.
Mm-hmm.
Yeah, well, I would just agree with what Crystal said and what Hannes said as well, especially when we're dealing with convenient samples, looking for these large data sets. Well, it's people that maybe are, if we're looking for more minority groups, they are a minority, so we might need to do more purposive sampling to be able to recruit those participants. And I think with that, there are possible benefits too in using qualitative research methods as well, because quantitative data does try to get larger sample sizes, answers certain questions, but certain questions can only be answered with qualitative data as well. And so if we're to compare different people's experiences under psilocybin as facilitators, that purposive sample could be very useful to get that type of data in. Yeah.
Absolutely. And, it makes me think about set and setting, and for some of the folks who were up speaking yesterday, conversations about wanting to, make their environment feel very supportive for the people that were coming in intentionally in supporting the LGBTQ, plus communities. I think that that's very important that we're tracking those metrics. We're looking specifically at, places where that's a goal, to be supportive in that manner. And although, we're not there research, I don't think yet
if we continue to collect that data, that's something that might be really important, you know, to set up your set and setting in that manner.
Yeah, there are some like potentially culturally specific things, not just for, you know, the LGBTQIA plus community, but like lots of other culturally specific things, right? So thinking about setting up treatment or clinical environments that are not only non-directive, but also like maybe just non-offensive or, you know, culturally appropriate. Yeah, that's something I hadn't considered. Jérémie, our audience is really interested in your perspective on whether you think people who have used psychedelics previously, do they benefit just as much from psychedelic therapy as those folks who are naive?
It's a fantastic question. Thank you, audience. I would probably have to touch base on the data set on that. I don't know how much naturalistic research has been done on specifically looking at people that have repeatedly used psilocybin. What I do know out of our clinical trials going on at Hopkins right now, a lot of them are looking at least 2 dosing sessions now. We're kind of moving away from the single dosing model, looking at using multiple doses, and there seems to be continued benefit when we're looking at 2. I don't know if there's a threshold in naturalistic research too, like do you still continue to benefit after 5, after 10, after 20, after 30? Is it what type of, is it linear or is it a different type of relationship? I think that remains an open question. But I would think that maybe at a certain point, these experiences might start being less meaningful or maybe confirm things that you've already learned. So maybe there's a process of integration that's more important there and what to do with those insights once you've already gathered them. But that's, you know, I would love to do that type of research given the opportunity for sure.
Yeah, I think potentially the Oregon model makes a really ripe environment for that kind of research, right?
Yeah.
Like we have no idea what, you know, what will happen. You know, I don't know exactly what the regs are. I think folks, there is a certain amount of time that folks have to wait before their next administration session, but I don't think there's a ceiling on that, right? There's no maximum number of sessions that a person is allowed to have. So that might be a really unique opportunity to study that kind of stuff. I think that one of the other opportunities in the Oregon model is going to be not just cataloging like these severe adverse outcomes, but, you know, like your work, you know, with HPPD, you know, how important is it for us to catalog these things that are like sub-threshold in terms of really impairing someone's, you know, life experience? You know, for those folks that are, you know, running service centers and following up with their patients, you know, how important do you think it is to track, number one, side effects like this, and number two, the magnitude of those side effects?
It's an excellent question. So I think it depends a bit on the perspective that you want to take. From a regulator's standpoint, probably what you want to hear about are the serious adverse events. Just to have a general sense of like how safe are these treatments. I think from a perspective where you don't just want to monitor, but also improve services that you offer and make psychedelics safer, what we do need is some kind of individual level data also on the subclinical range so that we can be better at essentially predicting what types of interactions between individual characteristics and the setting can lead to also lighter adverse type of results, or maybe even just a lower extent of improvements in some people, or some people might decrease on their well-being as opposed to increase what we usually see. And just to figure out how to mitigate these risks of serious adverse events, I think we also need to study kind of subclinical occurrences, for sure.
Yeah. One of our, a very brief follow-up, how long does HPPD last? You know, similar to the benefits question, right? Like how long do some of these unwanted effects last?
So, I mean, there are case reports of people who experience HPPD for up to 25 years after taking a single psychedelic, but that's very rare. So in most cases, it's weeks to months, sometimes years, that this will go on and off. There's different factors like other drug use and stress that can increase the intensity of the symptoms, sometimes for a short period, and then they might go away again. So very, very different idiosyncratic kind of patterns of how this condition really expresses itself.
I have so many of my own questions, so I hope the audience doesn't mind that I kind of shift gears a little bit. Unfortunately, my questions are going to have to wait because we're out of time. So please join me in thanking all of our speakers today.